Hey everyone, this is Sarah Caudle. I'm in discussion board 6 talking about opioid abuse. We're going to get started by talking about what opioids do and opioid narcotics act by binding to the opioid receptors in the CNS system. So various areas in the brain, spinal cord, GI tract, and other organs. And this decreases sensation and the perception of pain. So the presentation of someone that may be abusing opioids has several different components. It could be physical, verbal and nonverbal, and psychosocial. Some of the physical symptoms are related more to dependence or addiction, and that can cause withdrawal symptoms when that medication is not available in the same dosages or in the same amounts and on the same time frame. And those symptoms are restlessness, muscle and bone pain, insomnia, diarrhea, vomiting, spasms, and chills, and the generalized need to get where they need more of the narcotic in order to get pain relief, and this is also considered tolerance. Some of the verbal and nonverbal cues are problems with attention and memory, a lack of awareness and coordination, depression and confusion, and personal or hygiene neglect. Also, in my own personal experience, I feel some of the verbal cues have been that these patients are often more agitated and a little more aggressive if they're not getting the medications that they want or need and on the time frame that they want, and also have some manipulative tendencies in order to get what they want. Some of the psychosocial and behavioral aspects of a person who is abusing narcotics include sort of a generalized compulsive drug-seeking behavior where most of their energy and attention is devoted to getting the medication that they are addicted to. Use despite adverse consequences, and those could be either physical or social or relational, and doctor shopping, moving around from physician to physician to get prescriptions for the medication that they're addicted to. A few other of the key features, and this is from the Mayo Clinic, are things to look out for are problems at school or at work, tardiness, missing deadlines, or a generalized disinterest in the activities that they were once interested in, lack of energy or motivation related to their physical health, a neglected appearance, changes in behavior such as isolation or being secretive and neglectful of relationships. And then spending money, and it could be constantly borrowing or requesting money, stealing or selling items to get the money that they need to support their habits. Moving on to question 3, what are some of the best practices that we can implement to manage drug abuse and addiction? And this came from the reading as well. There's a few key things that we can do as providers, and that's ask the patients about all of the drugs that they take, how they take them, do they take them as prescribed. We can also screen for other risk factors like family history of drug abuse or alcoholism, depression, various things, or other addictive behaviors that might lead to drug abuse or signal drug abuse. You'd also want to set recovery goals with these patients. And finally, treatment. And treatment, of course, would have several different components because it does encompass physical, psychosocial, various different factors. So those would include detoxification, counseling, and it may require the use of addiction medications and multiple courses of treatment. The counseling part is very important, and it should address how to function without drugs, dealing with cravings, avoiding drugs in situation where drugs might be used or a person might be tempted to use them, and handling relapses. And this is all important in treating any patient that is addicted to opioids or really any other substance. Moving on to our personal experience and our clinical practice, I feel like this is an increasing problem. It seems like we have patients with addictions come in more and more often, and it's not diagnosed as they have this addiction, but it's very obvious by their behaviors that there is a dependence on medications. I can think of a couple patients in the past few months that I've had that were relatively healthy 30 to 40-year-old patients with no remarkable past medical history, no trauma or injury that would require use of chronic narcotics or the need for chronic pain medication. However, when I've looked through the chart, there's a series of readmissions for this nondescript, nonspecific pain, and they have had every test run in the book. So all of these, CTs, X-rays, even heart catheterizations, different scans of the GI tract for all of these epigastric pain or chest pain, and coincidentally, they have an allergy to morphine and Zofran, and they're so nauseated that they can't take anything in a PO form. So it's very obvious, going back to that manipulative behavior, that those that are addicted to medications know what to do in order to get the medications that they want. And in my clinical practice, I don't feel like in my 12 hours or less with a person that I'm going to change their addiction or behaviors. But I do feel that I can prevent enabling that client. So I've contacted the physician and said, look, this is what's going on. We run every test in the book. And this patient really wants nothing else but their IV Dilaudid Q2 or 3 hours. Nothing else. No other medications. They don't want to take their daily medications. They just want that. So we've got to do something. Otherwise, this person will stay here and continue this behavior. And we're not getting anywhere. So in one specific situation where that was happening, I talked to the doctor and they said, okay, well, let's expand the time frame out for the medication, or let's make it all PO. And we made everything PO form. And as soon as that happened, that person was ready to go, ready to check out. They wanted nothing else to do with us and didn't want our care or treatment anymore. Unless you work in a facility that's specifically related to substance abuse and counseling, I feel like, at least from a floor nurse perspective, our hands are somewhat tied. But I do believe that we can prevent enabling and making the situation worse. And then if the opportunity presents itself to help this patient and use that, then certainly we could use that window of opportunity. So that's it for this week. I'm looking forward to hearing from you guys. Thanks.